Hey everybody, it's Kevin and it's Heidi, and welcome to another episode of the Med List. You guys might be thinking, Heidi, we haven't seen her as a co-host of the Med List, but she is our guest today, and thankfully she will be my guest and co-host today because Donna is having some computer problems. If any of you have had a computer problem before, you know the pain. So keep Donna in your prayers, and hopefully she gets through that really soon. We'll shoot this through, but Heidi, I have a question for you. It's Super Bowl week. Are you going to watch the Super Bowl at all? And when it comes to sports in general, are you a yay sports person or are you a dedicated fan to one sport or another?
Oh my goodness. Yes, I will be watching the Super Bowl more so for the commercials. I'm not the
Mhm.
biggest sports fanatic, and I really enjoy sports to the extent that I like watching other people enjoy sports. I've never been a big fan or really have participated in a bunch of organized sports growing up, but I really like the infectious spirit that people get when they're cheering for their team and how excited and joyful everybody is when they are going, watching the game. So it's hard not to pick up on that energy.
Oh, I love it. I love it. Yeah, I think the fandemonium is contagious for
Yes.
sure. Well, that's so much fun. Walker household will be watching it. We'll be probably doing a little bit of traveling here soon, but it's always fun. The Super Bowl and those commercials. I mean, I always think how much money is being paid for the commercials, but other than that, some are pretty good. All right, well,
Yes.
we'll get things rocking and then jump right into our episode on Intro to Optimizing Physical Therapy. All right, everybody. So really fun one. And I'm going to have Heidi introduce herself on here, but my background knowledge of Heidi already is really impressive because our first kind of leap into the conversation of physical therapy, Heidi, you felt like you wanted people to know what physical therapy was. And I feel like that is a very astute position to be in. Heidi has backgrounds in both practice, so a clinical physical therapist, doctor of physical therapy with extra specifications and board certifications, but she's also a professor, so she's teaching it. She's doing it and teaching it. So huge applause to individuals that are doing that. It seems like we need more of you out there, Heidi. But please tell the audience more about yourself and kind of background and all that other good stuff.
Sure. So my name is Heidi Moyer. I am a doctor of physical therapy. I'm also a board certified clinical specialist in geriatric physical therapy, as well as a certified exercise expert for aging adults. I am currently an assistant clinical professor at Angelo State University in San Angelo, Texas, where I've been for the last probably about year and a half now, I think is how long we've been down here. I've been a physical therapist for 7 years. I am in clinical practice still. I do still treat PRN in both the acute care and the outpatient neuro settings. And I teach full time as my job, but I also conduct research and teach continuing education. So I have a lot of hats that I wear at times, but it definitely keeps things from getting boring.
Oh, that's fantastic, Heidi. And another thing that's fantastic, my colleague Donna was able to get it all
Hey.
connected. Yes, how wonderful.
Ah,
So
it's
glad to
nice
have
to
you
see
with
you here
us.
today. Go figure.
You
What
certainly
a
know how
great
to make
start
an
of the
entrance,
show.
Donna.
Yeah, Heidi gets through all the
I
tough work of introducing
know.
herself and sweating through all the details, and now Donna pops on. I love it.
Oh,
Donna,
man.
what was the trick? How did you connect to the internet and all things technological for
Um,
our audience?
Everything was shut down, even though all the lights were on. No one was home. Um, and so my husband just restarted the entire internet here at the house. So we got it up and running. But
Perfect.
yeah, so what are you going to do, right? Sorry. Thanks for your patience and glad I can join you.
It's nothing like a good reboot, right? That helps every once in a
Oh,
while. And I
I
feel like
know.
sometimes, Heidi, when you're talking about physical therapy, I feel like we wish that we could take our older or aging bodies and click the reboot button with a physical therapist.
Hmm.
But it's a lot more than that. And if you want to go in for us, Heidi, on just what is physical therapy? There's so many thoughts on, I get out of surgery or I'm having this or that issue that I'm noticing and I don't have the same range of motion or strength or et cetera. And I go see this individual that's an expert in this, and then they help me to get better. But there's more detail to that, and there's a lot more expertise. So please guide us.
Yeah, so you definitely have the gist of it. So we are the movement system experts. We are doctorate level professionals, which means that we have to complete not only a bachelor's degree, but also a graduate level doctor of physical therapy degree, which is 3 years on top of our 4-year bachelor's. And we're all over the place. We're in many, just about every healthcare setting you can think of. And our job is movement, and specifically looking at how movement is impacted from the musculoskeletal, so your bones and your muscles, the neuromuscular, how your brain's connecting to your muscles, as well as your integumentary, your skin, and your cardiopulmonary, your heart and lungs. So though we call those our four movement systems, where we have high health literacy and ability to positively impact people's movement experience, whether that is returning to walking or seeking alternative modes such as rolling, using a wheelchair, power mobility to try to maximize people's quality of life. Every specialty and setting is so different, but in general, we really work with our patients and clients to find out what's important to them, what they want to be able to get back to, whether that is after surgery, getting back to walking without a device, or following a fall or a potential hip fracture, heart attack. Really not only trying to add years to life, but life to the years that people have. And that's really our role as physical therapists.
Wow.
Love that.
How, in general, Heidi, would you differentiate things that physical therapists do versus other associated colleagues in the physical and movement kind of pathways?
Yeah, so there's a lot of overlap with us. And actually, a lot of us come from some of those more exercise physiology, athletic training, personal training backgrounds. So it's very easy for people to get confused, just, physical therapist versus personal trainer. So some of the differences, specifically starting with personal trainers, you do not have to have a college degree to be a personal trainer. It is a certificate program. Now, I have met some very well-educated, well-trained personal trainers who very much take it upon themselves to stay educated and stay up to date on current trends and information in exercise and science and health. So that's not to say that just because they don't have that education level that they're not good at what they do. They are kind of healthcare adjacent. You'll find them in healthcare clubs. Sometimes personal trainers are working under physical therapists or doctors in outpatient clinics. We also have our athletic trainers. That's typically a bachelor's degree. You can get a master's and a PhD in that as well. A doctor, not PhD, but a doctor of AT, a doctor of athletic training. They work much more with our sports populations. I was actually just talking about this with literally next door in my office complex here on campus. I have a doctor of athletic trainer next to me who we went through orientation together. And he said that his view of our differences was very much like he is on the sidelines, on the field, working with athletes, trying, making sure emergency measures are in place, more damage is not potentially being done if there is a true injury, screening in and out all these, head injuries and concussion, and making sure people are safe to return to play. But as far as the more medical side of things, once people really need that surgery initially and they're having a severe problem with, they get a severe brain injury, they can't walk at all, that's kind of where the handoff happens. So yeah, those are I feel like those three are kind of the personal trainer, athletic trainers, doctor, physical therapists. We very much overlap in our education with the rest of the allied healthcare professionals. We also overlap a lot with our occupational therapy colleagues. It was kind of a running joke of the OT walks into the room and the patient's on the phone and says, "The PT's here," because we do a lot of the same things. There's a lot of overlap as far as movement. Our occupational therapy colleagues are focused on people being able to dress and bathe and groom and cook. They take care of what we call ADLs, activities of daily living. It's basically what you need to do to take care of yourself. Get yourself clothed, get yourself clean, make sure that you're fed. And then we are kind of looking at taking that person that takes care of themselves out into the world. Can we go up and down stairs? Are we able to access the community? Do we have enough endurance to do so? So we get a lot in our doctor physical therapy graduate degree. We get a lot of education on health conditions. So we don't diagnose health conditions, but we do participate quite a bit in the differential diagnosis process. So we need to have a high literacy there. Understanding how to rehab somebody who is fresh from having a heart attack. Understanding the precautions and the metrics that we need to be aware of for those. There are some restrictions in place that we have to follow. And then sometimes there are people that fall outside those boundaries. And then we have to use our clinical reasoning to figure out how are we going to get this person better when we don't have a direct guideline. So those are kind of the big differences between the groups. There's a lot of overlap, but that's kind of the main differences.
Beautiful. I love how you wove those together. My last one, Donna, for Heidi on kind of what is a physical therapist is really this. before we jumped on the show, Heidi, you're really educating me on what was a physical therapist. Like this was the previous notions of what physical therapy was versus what it is today. Can you walk us through that a little bit too, Heidi, on what if an individual is thinking, my grandma went through physical therapy and this is what it looked like versus now I'm going to physical therapy. How could that have changed over this period of time? And what are some of the new and exciting things happening in that world?
Yeah, so our field has drastically changed in the last 34 years, which I think is also where people don't always know what we do until they need us. So back in the 90s, we were very much kind of physician extenders in the sense that
Mhm.
the physician told us to do heat ultrasound massage, and everybody, regardless of what they had, got heat ultrasound and massage. And it wasn't really until the early to mid 2000s that we really started to build our research base on outcome measures, performance measures, screening, assessing, special tests and whatnot for that. So I think some of that information had always been around, but it wasn't the general norm. So we've kind of evolved into this more exercise, movement based, highly skilled doctorate level profession. Back in the 90s and then the 2000s, we were a bachelor's degree. Even before that, we were
Mhm.
an
Yeah.
associate's. So, we went from bachelor's and then mid 2000s to early 2010s, we were a master's program. And now all of the programs that are accredited have to be doctorate level. So there's just been so many changes in the past that if somebody did get therapy in the early 2000s and they show up now, it's going to look like it's an entirely different field just
Wow.
because it's not what it was at all in the past. We've made some amazing changes. We still have a lot to go, and we've got a lot we can do a lot better for sure. But we're slowly getting to where we need to be.
Wow.
So, Heidi, it's funny that you say that and you put in that timeline because my eighth grade teacher had said to me, "What do you want to be, Donna, someday?" And I said, "I want to be a physical therapist." He goes, "No, let me think about it." He goes, "I'll get back to you." And in the middle of algebra, he turns around and he points at me. He goes, "Pharmacist, own your own pharmacy."
That's so funny.
And then it was a PT was a 2-year program, and I think he was thinking,
Mhm.
"No, no, you should go to school longer than that," you know?
Yeah.
So it was just a very funny, conversation throughout my 8th grade years.
And it's
So
so funny because we started out so nobly. So actually the origins of physical therapy was after World War I. The reconstruction aids were a branch of nursing actually. So what
Mhm.
had happened was, we talk about World War I being a war on a different level scale because now we've got tanks and airplanes and all of these, horrible war machines basically. But now not only are we seeing horrible war injuries, but medicine caught up and these
Right.
people are
Mhm.
surviving these bullet wounds. So people are surviving amputations and deformities and burns because medicine caught up, but society wasn't ready for these people. We didn't
Mhm.
have ADA. We didn't have, accessibility on the level that we do now. And of course, it
Yeah.
can still be better, but we didn't have any of that. So it was a group of nurses that were like, okay, we're not going to let society shun these war heroes who risked their
Mhm.
lives to go over there and fight for the cause. So they actually trained them in exercise and movement and, equipment, basically creating equipment from scratch, just out of their imagination to get these people reintegrated into society so that they could go back to their families, they could work their jobs, and they could do what they
Wow,
needed to do. So
that's
we kind of
amazing.
bash on 90s therapy, but we come from such a noble start that I want to make sure that we talk about that too.
Yeah.
'Cause
No,
we're
I think
always
that's
evolving, but we
exciting.
have a pretty neat start.
Yeah, absolutely.
Wow.
So, um, Heidi, thanks for all that great information, and I think what's really important, what I I liked about what I read about you and what I know about you through our previous one of our previous guests, Veronica, that was with us during season one. Um, but when I was going through your things, I noticed that you are specializing in geriatrics. So it's a board certification in geriatric physical therapy. I'm board certified in geriatric pharmacy. So I'm like, oh, this is kind of cool. And I know that there are people, of course, in PT that specialize in specific areas, but I didn't realize that there were these board certifications, et
Mhm.
cetera, too. So that I found super interesting. But I know that we also want to talk about, this whole medicine side and PT side, and where our two worlds combine and really intersect. So I would love to hear a little bit more about the geriatric specialty, and then how medicines have become an important part of what you do.
Yes. So our board specialty process is basically advanced. There's a couple of requirements depending on which specialty you seek, but for geriatrics, you have to have 2,000 contact hours with that patient population, and then you have to sit for an exam. So the board certification process is lengthy. It takes a while to study for, but I always tease that the geriatric specialty is the generalist's specialty. So we're working with older people, we're not just looking at the age, but we have to know all of the four movement systems. Then we have to know what normal aging looks like because there are some changes. Then we have to know what those pathologies look like on top of that. It's kind of like when the music speeds up during musical chairs towards the end, is how that specialty feels sometimes. But a big part of our board specialty is actually pharmacology, pharmacokinetics, pharmacodynamics, and being able to
Awesome.
incorporate medications in our decision making and at least screen and have better knowledge. We're certainly not to the proficiency level that pharmacists are, but it's more advanced training than just kind of your generalist new grad physical therapist, which is definitely one of the things that sets us apart and also helps us to have a overlapping health literacy with the pharmacist on our interdisciplinary team.
That's awesome. I love it.
What does
Um,
that mean for
yeah.
specialties? Was curious, Donna. But and Heidi, this is just a point that I'm interested in is when it comes to the specialization of like geriatrics in general. I love it, love that population and that group. But when it comes to ailments, diseases, et cetera, that you are working with in particular and really have an expertise in, can you give us a little bit of flavor of that for the audience to hear? Like, this is what Heidi does on a regular basis, or these are the kinds of patients she sees on a regular basis?
Yeah, so it depends on more recently now that I've moved down here to Texas, whether I'm in acute care or outpatient neuro. But I do in the past and kind of the population that I'm most comfortable with and have the most clinical skills in are dementia and brain injury. It takes a very different type of person to work with those two populations. I love being kept on my toes. If I'm just bored, my body's just going to give up on me. It's what I think. But those are kind of the two groups that I like to work with the most. As far as kind of the populations and people that I see in the clinic right now in the clinic where I'm working at for outpatient neuro, I see a lot of post concussive fall balance and falls issues, stroke, MS, which is interesting. We talk about that geriatric specialty because even though we're focusing on older adults, a lot of that knowledge and that studying actually has to start in young adulthood because many of these conditions do not begin once it's not like you turn 65, you get your AARP card, and then you also get, dementia. That's not how that works. A lot of the
Yeah.
lifestyle choices that we make and are even, that are made for us in our childhood, and then that we make for ourselves in our 20s, 30s, and 40s actually predicate the risk factors of some of these diseases, what makes things more likely to happen. If you are already genetically predisposed, if you are already genetically disposed to potentially having this condition, will it potentially pop up sooner because of some of the lifestyle changes that you've made? So even though I say, I'm the older adult specialist,
Yeah.
I still work with people in their 30s, 40s, and 50s and counsel in health behaviors and be like, look, this is what I do for a living. This is where I can kind of see where you're heading. Like, let's have a conversation and see if we can make some positive changes now so we can try to avoid what might be coming down the way.
Yeah,
Wow.
for sure. That's
So,
great.
but yeah, as far as kind of the populations I've worked with the most, I've been in inpatient, home health. I worked in long-term acute care hospital, which was my favorite. I worked on the ventilator weaning team, just towards the middle of like the COVID pandemic. It was a lot of fun working with people who are minimally conscious, so they're aware of what's going on around them. They can interact, and getting those people standing and sitting, walking,
Wow.
while they're still fairly out of it and not are able to follow motor commands is a lot of fun. So I,
Wow.
I work with a very niche specialty, but I have a generalist knowledge.
That's awesome. That's amazing. So, what do you see in the way of, I'm going to jump to it, like medication? So, I'm of the idea that medications can keep people from progressing and getting better and being able to do physical therapy if they're over medicated. So, maybe their balance is off, their cognition, they're too fatigued, whatever it might be. That could be side effects to medications that would be problematic for wanting to
Mhm.
exercise and wanting to, or even being able to. So, I mean, I have a whole host of meds, but are there certain things that you actually target and think about when you're looking at particular medications? And just how do you go about talking to patients or talking to
Mhm.
providers about trying to deprescribe?
Yeah, man, that's a great question. So, kind of to give a little bit of overview as far as like a typical workflow for physical therapy professionals, unless you're in home health, it's really not part of what the healthcare team expects us to do as far as medication reconciliation. So, in home health, if we start an episode of care, we are expected to sit down with that person, go through every single medication, find every. We affectionately call it the Easter egg hunt from hell sometimes, because people store medications in different place, right? Okay, these are my morning meds, and they're in my bedside table because when I wake up, that's where they need to be to remind me to take them. But then we have to put them all together and figure out, do you actually have what the hospital thinks that you have, and when's your next, all of that. So outside of that, we really take more of like a reactive approach to deprescribing when problems pop up. I think I'm a little bit more proactive than most, mostly because Veronica has convinced me that it is a very important thing to do, and I've read a very important book that also told me it's an important thing to do, called MedStrong. I don't know if you've ever heard of it or
I
not, but it's
no,
a really great
no.
book. It was a fabulous read. But as far as some of the medications that I keep an eye out for on the front end when I'm evaluating somebody and taking them in, as well as doing their eval, because I've had a handful of patients where it's like, this is not a PT problem, this is a med problem, as
Mm,
well as really focusing on how it could potentially interact with our exercise interventions, any type of pain meds, especially our controlled class medications, opioids. That's a big one that I look
mhm,
out for, especially trying to get them off of those meds a lot. Those are usually
mhm,
the medications that cause the prescribing cascade, right? Because you take the opioid, then you've got dry mouth, and now you've got constipation, and now we have this whole cascade of things. So we try to get individuals off of those as soon as possible once they get moving. Antihypertensives are a big one as well for us. So we have a lot of patients with comorbidities of hypertension, and antihypertensives, I think, are a really good example of medication being a tool, and it's really how you use that tool that determines whether that is a positive or a negative thing for the patient. We need to make sure that we're controlling high blood pressure so that we're reducing cardiovascular risk and stroke and later on. But too much of a good thing is a bad thing,
mhm,
and I'll
mhm,
see a lot of patients throughout the different settings that I've been in be on too much of those medications, or they lose weight and their
mhm,
medication dose has not been adjusted, and all of a sudden they're tripping and falling and they're dizzy and they don't know why, and it's like, well, my goodness, good for you, you lost 50 pounds like you wanted to, but we haven't changed your doses yet on anything, so no wonder we're having problems.
yeah,
um, we're also looking out for a lot of our movement modifying medications. So I also work with a lot of individuals with Parkinson's disease, and a lot of the dopamine agonists or dopamine replacement medications are really good example of making sure that we're on enough, but we're not on too much and not on too little. Kind of that pendulum, right? We talk
yeah,
about.
yeah,
We need enough to make sure that we're positively impacting the motor symptoms, so that person
mhm,
can move and their balance isn't impacted and they get more physical activity, and which helps with the depression, anxiety, and the sleep
yeah,
and everything that comes with the sleep
mhm,
disturbances that come with Parkinson's. But then too much of it, and we start to have all of these other issues. So um, I see a lot of on off times with those meds. I think those are really the big ones. Beta blockers are another
mhm,
one that I always look out for. Not as much so much as like, oh, this is causing a problem for my patient, but when we
mhm,
are trying to get to moderate to high intensity exercise dosing, that can sometimes blunt their tolerance or make it hard for them to tolerate that higher exercise. We also usually use their people's heart rate to determine how hard they're working, and if they're on a beta
mhm,
blocker, we have to either mathematically account for that or use more of a perceived exertion, like how hard do you think you're working, or watch if they're sweating, or some of the other signs to know that we're probably
Sure.
hitting the difficulty of the exercise that we're
Hmm.
looking for. So
Great.
those are really the big ones. And then as far as your other question as to how I participate in that deprescribing process, so PTs as a field I think are more reactive. I think we are better at this than we think we are, because we will very often have these patients where everything looked good on eval, things are we're doing our exercise dosing, we're doing exactly what we should be doing to get that patient better, and they're not getting better.
Hmm.
Something else is happening, and that's usually where we step back and go, okay, is there a medical issue that we don't know about, or the patient doesn't know about? Sometimes we're the first to find something and report it. Is there a medication that's stopping us? Do we even have the right nutrition? I get a lot of patients that are sub 1,000 calories a day. They're not eating enough. And if your body's in starvation, it's definitely not going to want to exercise. So they're not going to get
Hmm.
better. Um, so that's kind of more of our process as to how we're kind of approaching all of that.
Yeah. Amazing. Um, I have a couple of other questions in regards to some things that I've learned about kind of recently in the field of PT, and some I've known about. But I know that there's some specialists that work with vertigo. You talked about dizziness, but then there's also the pelvic floor exercises and PT that it seems to be becoming more mainstream, I think, for folks. And so I'm wondering with that, so if somebody has vertigo, for example, and they're being treated with the meclizine or other um, medications for that dizziness, are when is that being taken away? And is it being communicated like, oh, they have this treatment, they might not need this meclizine anymore? Or even with the pelvic floor exercises and urinary incontinence,
Mhm.
are we looking at what have they been using for meds? And are those medications used for urinary incontinence now being communicated like they probably don't need this any longer?
Yeah. Yeah, I know on the PT side of things we are, and I'm glad you bring up meclizine. I'm adding that to my list from the question earlier. So actually, for vestibular therapy, we have to run tests that actually cause the symptoms, which can make people feel awful. The first day of vestibular therapy is the worst day of vestibular therapy. People actually need to be off that meclizine for about 72 hours before they come in. Otherwise, their system, because it's a nervous system depressant, there to stop the symptoms and the dizziness and everything. We actually need to see what's causing. The different tests that we do help us figure out, is this a nerve problem, is this an inner ear issue, is this a brain issue, something else going on, an autonomic dysfunction, with blood pressure or heart rate not coordinating quite properly. So they actually have to be off those meds for us to test them. I've gotten, especially in this outpatient neuro clinic I'm at right now where I PRN, we get a ton of people that have been on meclizine, please everybody sit down, for years,
Mhm.
and they have such a depressed, basically their vestibular system's no longer active. Sometimes we're lucky and it's just on one side, sometimes it's on both sides, and trying to convince somebody to get off of a medication like meclizine when it's been their lifeline for 2 years
Yeah.
is a
Yeah.
huge health change for these folks. So we're
Mhm.
doing a lot of education of physicians around town and everything, and people don't realize
Mhm.
it's supposed to just be a 1 or 2 day rescue medication, and they'll prescribe it for weeks to months.
Yep, they
And we
do.
actually have to have people off it. And then when people come into us and it's the first time that they've seen us and we're running these tests and these assessments, even if they're off it for the 72 hours, the effects are still there. Sometimes we're lucky and we can find what the original problem was and fix it. But then we're going to have to spend probably months to correct this, what we call a hypofunction, where now we've depressed the organ so much it's no longer working. Our vestibular system is supposed to be sensitive. So yeah, so that's a big one. That is definitely something that we're
Mm,
talk before people even come in, when they're like, oh, I have vertigo, like, okay, when we're scheduling appointments, what medications are you on? And you need to make sure, this is your appointment
mhm,
date. I need you to stop taking it on this day. Plan ahead, do whatever you need to do to take care of yourself, but please keep off this medication because we can't fix the issue. Um, there's a
mm,
lot of different things that cause dizziness, but
mm,
meclazine's a pretty big go-to. The pelvic health side of things, there's a lot of education as far as looking at what medications people are on for incontinence. I don't do pelvic floor therapy a lot. I do incorporate it. It's definitely not something there are a lot of specialty clinics, and I'm so glad that it's a topic we're talking about more now that it's
Mhm.
just not as taboo to discuss pelvic
Right.
floors because everyone's got one. Um, we all have a pelvic floor, and it all needs to work properly for us. I do know, especially as we're talking about like anticholinergic burden and everything, there's a lot of medications that cause incontinence or retention of bladder, and I would love to see that education improve overall, not just in PT education, but in general medical education. Like, what's actually happening when you give these medications, and was this new problem actually a new problem, or was it a
Right.
problem from this medication that we're seeing? So,
Mhm.
I do know that from the pelvic floor specialists that I know, that is a part of their workflow. They're looking at meds because half the
Mhm.
time I had one friend said, yeah, half the time I just do a med review. We remove a couple things. I do a few follow-up appointments. They're fine. I don't even have to do an internal exam because I've identified up front it's a med thing. She's like, that's 50% of my patients. I'm like, first of all, good for you for looking at meds. Second of all, ugh. I'm so sorry that that's coming your way.
That's amazing,
Gotta
right?
ask because I have two young boys, Heidi, and they're gonna love they hear their dad say this word. But when it comes to proper poop positions,
Yeah.
like what are you seeing right now in research? Because I feel like that is, as you mentioned, a taboo subject that I hope people listening know that it's a real problem for a lot of people. Like
Hmm.
having continence and incontinence issues, having anal issues related to the vasculature that surrounds that area is a real
Yeah.
problem that people just don't like to talk about in general. But one thing that we don't hear about is you're little. Usually you don't get a full breakdown of this is where your knee position should be, and this is how you should be going about an appropriate bowel movement, which we pay for later on in life sometimes. Give us
Yeah.
some thoughts on that, Heidi. I mean, maybe not go into the nutritional elements of adding additional fiber, and it matters what the substance is that we're actually trying to excrete, but
Yeah.
just in general, like positionally, what's going to be good for our folks that are listening to go, oh wow, I just learned something today.
Yeah, I was going to say, Kevin, that was going to be the first place I was going to go was fiber and hydration. A lot of times people are very dehydrated and that causes issues. And if it's
You-
too hard to pass, then it's tough. That squatty potty was no joke. That is actually the proper defecation or pooping position.
Yep.
When you get your knees up higher, it opens, and especially not only up high, but wide. Think about kind of like that birthing position that we typically see people on their back with their knees up. That helps to some extent. There's better positions to actually do it in, but it starts to help open up the pelvic floor a little bit, which is kind of what you need to be able to relax those muscles to allow things to pass through, whether that be a bowel movement or a child
Right.
that is about to be born. So, but yeah, definitely getting the knees up a little bit higher, which I have found is actually easier. I don't know. The next time any listeners on here go to a public toilet, think about how low that is. I have always found I don't know if it's just been me. I've always found public toilets to be so low. And then, but sometimes a little bit of magic happens when you're in there, and it's maybe tough to get up off afterwards. But the public toilets tend to be a lot lower, which is a pain to get off of and on. But it's actually a much better position. That's also, as you're talking about, you have kids and everything. They actually have a child's version of the squatty potty. Um, I don't have any stock in it. It's not a product recommendation. But it is because if you think about especially kids or shorter people trying to go to the bathroom on a toilet, if
Mhm.
your feet are dangling, you're not in the right position. But getting those knees up at least higher than your hips does help to straighten out your colon. Just kind of a little bit of physiology lesson. So your rectum does not hold poop until it's ready to actually defecate it. And your rectum is kinked when you're just kind of in normal standing and sitting position. And you start to lengthen and elongate it to allow it to accept the bowel movement from the large intestine to then allow your body to generate enough force to expel it and open your internal and external sphincters. So that's the long and short of it.
The long and short. Well done. Well done. That's perfect. I think that when it comes to things that we all do and may struggle with at one time or another in life, that's one of them.
Yeah.
And I think the other one that, for an anecdote for people listening, for another just key takeaway, the sedentary lifestyle, Heidi. I'd love to get your thoughts on that from your expertise as a physical therapist. And, we went over there, Don and I could, pontificate and add some additional components when it comes to constipation and incontinence, pharmacological therapies that end up getting put on board unnecessarily, sometimes often, or ineffectively, and just not monitored appropriately. So I think there's a lot of collaboration. But the sedentary lifestyle piece, there is a real attraction that Don, I've had lots of outside conversations on GLP-1s. A lot of people are familiar with the brand name drug of Ozempic, that are being used to just lose weight in general. But we're not addressing a big problem that I'm guessing you're seeing in a whole nother way when it comes to we sit in this chair staring at a screen all the time, or in a recumbent position in a recliner, staring at a TV more often. What are some things, Heidi, there that you're like, I'm seeing this more often in my patients, and I wish that my patients would start doing these things to assist?
Yeah, that the sedentary lifestyle and the lack of physical activity is literally a killer. Um, I think that kind of the big issue with a lot of our messaging, because we know the research, the more you move, the healthier you are. This is kind of a duh, right? We all are aware of it, but I think where we really miss the mark on making sure that people meet their minutes or get more active is sometimes I think that we set such lofty goals for people, or people feel shamed if they can't meet, 150 is the magic minutes. I can tell you, I meet that a handful of times, 150 minutes per week. I meet that a handful of times throughout the year just because of different things going on in my life. And I think that with influencer culture, social media, there's such a push to be perfect. And if you're not working out 3 times a day, what are you doing? And oh, I drank 14 liters of water. There's such a
Those Stanley Cups,
there's such a showboat culture. Yeah, exactly, right? Be careful with those Stanley Cups. There's such a showboat culture, I think, sometimes to physical activity, and physical therapists are guilty of it, right? It- I think it's so important for us to level with our patients, and the current Surgeon General recommendation. They talk about 150 minutes per week and strength training, all of your muscles twice per week in balance. I love the caveat of be as physically active as you can. When you've got stuff going on, life's happening, you've got medical conditions, move more, sit less. Some is better than none. And I love that recommendation because I think it makes it so much more realistic. Because on days when I'm, working 12 hours, I'm in the clinic for half the day, I'm in the classroom for the other half of the day. The last thing I want to go home is do a high intensity work exercise. Have I gotten some physical activity throughout the day? Certainly. Is it structured as to what I maybe should be doing? No, but maybe just a walk is good enough, just to do a little bit of mental health care. So, we know the research on physical activity, but one of the things I've been doing less and less in the clinic is actually prescribing exercises. And this is kind of a hot topic in PT. I don't prescribe exercises, I prescribe activity. So early on with people who are very deconditioned, or even people that are more athletic, I tell them, pick an activity you like to do and do it. Do you like to mall walk with your lady friends? Do you have the ability to stand up and just take an extra loop around the kitchen during a commercial break? Can you just go for a walk outside? So I've found that if I give patients a physical activity home exercise program and say, okay, you live in it just makes it much more tangible for them. I have a lot of patients, especially my older adult patients, who are already going to the gym and they're already riding the machine. So I say, okay, great. Here's an intensity chart. This is how hard I want you to work. Get on the machine. Let's work here for 10 minutes. Did you feel how hard you were working? That's what I want you to do when you're not with me. So I have them really work on that activity, and especially because then it becomes something that they're going to carry over when they're done with me. The numbers on compliance for specific exercises are all over the place. If you've got someone that's really into it, yeah, they're going to do it for forever, and for years and decades. But that's not the majority of our people. So getting them plugged into an activity they like, whether that's mall walking, riding a machine, pickleball, just so they can do more, is better than having them, giving them this very specific, beautiful exercise program that they're never going to do because it's just not realistic for them.
Wow, that's super insightful. I would just, before the show, there's a University of Cumberland's broke down the top 7 changes in physical therapy, and I think you just hit on like 4 of them right there. The gamification element, adding something that it's not prescribed exercise, it's activity, and then giving them some kind of goals or things to be able to meet. The one thing I did want to ask you on all those elements, the 150 minutes, we're looking at the X number of steps per day, depending on which camp you're kind of sitting in. Are you seeing more benefit when it comes to just activity overall from those that are using wearables?
Ooh.
The wearables, for the audience, just so everybody knows, your Apple Watches, your Fitbits, all of those things that are kind of commonly used out in society. Apple Watch and Fitbit, if you want to sponsor the Med List, then please come on board.
Let me get it on that. Yeah, because I recommend those all the time.
We're going to
And
read you his anticholinergic burden.
yeah,
Okay.
I think it really depends on the individual using it. Usually the people who don't already have a wearable, but they go out and they get a wearable are already motivated to make a health change. And I think those people are going to succeed no matter what. There have been a handful of people. There's one actually that I have a great story about this. So in home health, in my previous life, when I was working in home health, I was specifically working in an older adult community, and it had independent living and assisted living. And I was in independent living. Was treating one of the ladies on the floor. It was January, and she had just gotten an Apple Watch from her daughter. Her daughter more got it because that was the time when Apple Watch is like, oh, by the way, it can detect a fall. So her daughter got it as a safety measure for her to wear. And she's like, oh, I don't know if I like it. So I showed her, I was like, hey, you can get steps. I was like, look how cute it is. I showed her we could buy different bands that could match all her outfits, much to her daughter's chagrin. I was like, whatever we can do to get you to use this more. And she's like, oh, I didn't know it caught my, was doing my steps. So she had gone down to dinner that night and told all of her lady friends and showed off her new watch and everything. I'll be darned if by the end of the week they didn't all have one. And they entered into a competition. They started a walking group spontaneously because they had to close their rings. They had to get their steps. So, in that case, this is why I always say peer pressure is not a teenager thing, right? Peer pressure is a human thing. Sometimes we can positively manage that, but I wouldn't say necessarily that like a specific wearable or anything. I know there's been some really cool research looking at wearables tracking activity to help us get some of that data that we can't always be present for. But I really think it's the person who's willing to use it. Usually those people are more motivated and, they're going to succeed no matter what we do.
So, Heidi, if I can just kind of go on those coattails of what you just talked about, what I think is so important is that we providers and also patients and consumers know that numbers can change just because you might be a little frail, might have had a fall or something like that. You can move that scale, and you can start moving at any age. Like even if
Yeah.
exercise has not been your thing, pick an activity, right? And not necessarily an exercise, but I am amazed to see how movement in older adults who think, oh, I can't do this, even if you're lying in bed, move your legs. If you're sitting up, move your legs, move your arms,
Yeah.
do whatever you can, kind of thing, and just get that body moving because it works if you do that and you can progress. And the fact that you like, oh, all these women are now doing walking and they're having their walking club, that is wonderful.
Yeah, and I love that you mentioned numbers too. So part of our physical therapy, plan of care is at the initial evaluation and at discharge, we do what are performance outcome measures basically, where we're looking at balance and strength. And I always love to show people those numbers. I love to use those as an educational tool and explain, okay, you did this sit to stand test 5 times in a row at this number. This indicates that you are at increased risk for falling. Here's how we'd like to address it. And I love, and normally between that for insurance reasons, and just because we like to see how people are doing and check in between that intake and discharge, is we do a progress note. And I love to show people their numbers and say, oh, look, you're normal on this now. Keep doing what you're doing. We don't have to worry about this anymore, but now we're going to focus on this. That's still a problem, has improved, but we need to focus on this with the rest of our time. And I think those numbers can be so motivating for people to actually see their progress and experience and go through it. I also love to show people that they can do things that they don't normally think that they can do. One of the things I do a lot in my clinical practice is floor transfer training, because try as we might to prevent falls, so long as there's gravity, there's always a potential we could end up on the floor. And I want to know that if something disastrous happens, that Mildred can get herself up off the floor and call for 911, and she's not laying there for 4 days before someone finds her. So I do a lot of floor transfer training, and the look I get when I tell people I'd like to see you get on the floor, for people that haven't done it in a while, is like I just asked them to do a backflip. I'm sorry, you want me to do what? And then these people usually by the end, after they trust, if we build that trust and they start to do some of the wacky things that Director
Right.
Heidi says to do, they're just so impressed with themselves, and they tell everybody
Yeah.
about this thing that they could do, and that's very
Right.
motivating for other people.
Yeah.
But yeah, those numbers, and then them just physically seeing what they're actually capable of and tracking their progress with you is so powerful to actually
Yeah.
show, like, yes, we can reverse frailty with enough nutritional and interdisciplinary support.
Yes.
We can reduce fall risk. We can prevent falls. We can help you get up off the floor. We can make you stronger. Everybody, responds to that.
Love that. What
Wow.
a great ending, I think, Kevin, right?
Oh yeah, I think that's well, it's perfect because and kind of it's kind of cheating on our side, Donna, because you bring someone like Heidi that already is motivating me to start doing more things. It's like, well, if
A
I'm able
burpee a day.
to do as good as you, then wonderful. I think the only thing I have, Heidi, that really is left is what you and I talked about in the beginning of or before the show. It's someone just gets a new diagnosis or they've had a problem and finally their physician says, "Hey, I'm going to send you to PT." What's the way that they can, from the patient's perspective, how can they be more successful working with the physical therapist and gain the advancements in movement or the end goals that they really want with that process?
hmm so my biggest advice for people who are working with a PT for the first time ever in their life, or maybe with a new physical therapist, perhaps it's a different specialty, you need to see a different person who you haven't seen previously, is don't be afraid to communicate every issue that you think you have, no matter how small it is, and ask questions. The unique thing about working as a physical therapist is I get to spend a lot of time with my patients, and I really get to know them. And sometimes things pop up and patients will report things that they don't think are important, but are
Oh,
extremely important and actually completely change the game on what we're doing. I call it reporting, not complaining. And a lot of times I hear my
Mhm.
patients say, well, I didn't want to complain. I didn't want to burden you. It's like, what do you think we're doing? I'm here for you. This 45 minutes is
Mhm.
your time, Bob. Like I'm here. This is Bob's time. Like, what do you want to do? What do you want to talk about?
Mm.
So I always try to empower my patients, and I want to empower everybody who's listening to this podcast. You are not complaining, you are reporting. We cannot fix the problem unless you tell us. I have had patients who have had incontinence for decades, patients that have been dizzy for decades, patients that have been nausea from their medication for weeks and months, and they didn't want to bother the physician. They didn't want to bother us. Bother me, make it my problem. I want to fix it. So don't be afraid to tell your therapist what you want to get out of that session. That's literally what we're supposed to do, is ask you what you want. So go in there with a plan. Say, this is what I want to get back to. Tell me how we do it.
I love that, Donna. And I think that you and I would both emphasize this piece is just because you're going in because you just had a hip replacement done doesn't mean the only thing that Heidi and all of her other colleagues can help you with is that hip replacement and getting
hmm
you back to rotating your hip, right? I
Yep.
mean, there's so many other elements that a physical therapist can help with that you might not even think of when it comes to nausea, when it comes to dizziness, when it comes
Mhm.
to X, Y, and Z that you can bring across their table. And the worst thing that can happen is they can say, I would have to refer you to another colleague that could be a pharmacist. It could be an occupational therapist. It could be whatever the case may be, but a great resource. So thank you for highlighting that, Heidi.
Yeah.
Donna,
I mean,
any other things before we wrap things up?
Just on the clinician side of things and thinking about, all the providers out there, I think as we talk and as we have so many guests on, Kevin, too, this whole interprofessional education between us is so important. And, Heidi, just thank you for highlighting so many things and giving us some aha moments like, yeah, that's what we try to get forth. And so
Yes.
thank you for that. It was perfect. And I just look forward to working with you some more and chatting some more with you in the future. So thank you.
no, thank you
Well,
so much for having me.
awesome. Well, thank you so much, Heidi. It was wonderful. Thank you, everybody, for joining us. Hope you got tons of info out of it. I know that Donna and I sure loved it. And if
Yeah.
you're having internet or connectivity problems, I'm going to put Donna's email at the end of this so that you can get a hold of her and she'll set you right up. Everybody have a great day.